Hello, good evening, friends. At the outset, I am thankful to Academy of Pediatrics Ahmedabad for giving wonderful opportunity to talk on a topic I think which is very close to my heart. And as you all know that I am a common practicing pediatrician, so I'll be talking more for the common practicing pediatrician and which will be very useful in our day-to-day practice. So today I'm going to talk about the common office emergency procedures in a pediatric OPD. So friends, this talk, I have a very clear disclaimers that this talk is specifically designed for the practicing pediatrician in a resource limited setting or a practicing in an individual practice with unavailability of the specialist health. So when you are practicing in an area where you have the super specialist or so-called experts, which they are far away from you, and you are the only person, lonely person who are managing a show, I think this talk is specifically for you. View, views and techniques which are displayed here are having some references in the literature, and they have been innovated as per the need of the situation. So yes, these techniques can be utilized during a select situation only. So you have to properly choose the situation, and then you can definitely use these techniques. So first question, which is very common and very important, that is, which are the common emergencies which a practicing pediatrician faces in office practice? Now, answer, we know that as a pediatrician, we can face a lot many emergencies. It may start from head injury to burns or scalds or electrical shock or a fracture, or it can be a medical emergency. Anything like diabetic ketoacidosis can be there, convulsing child, severe dehydration, even a respiratory distress. These all are emergencies for us. Even a surgical emergency like acute appendicitis or torsion testis or finger crush injury. So many emergencies. Now let me reframe the question. Which are the common emergencies which a practicing pediatrician faces in an office practice which need an emergency procedures? Now here we have very limited things because there are limited. Suppose if you say in an anaphylaxis, that's an emergency. You will definitely manage with adrenaline, but there's nothing procedure which can be done. So these are certain emergencies where there are procedures which are useful. So this talk is dedicated to person like this fellow who is all alone in the middle of the sea and managing a show. We pediatricians, we are particularly in private sector with a single person managing the show. I think we are working 24 by 7 and 365 days a year. So on a fine weekend or Sunday evening, when we get a call for emergency, we are there, but there is no other help available to us. So we need to help ourselves. So that's why these procedures, these videos, and this talk are going to be very useful and important. So what are the troubles and troubles that requires the emergency procedures? So here I would like to be touching on the majority of these particular procedures, like situations where we are going to do a very useful and innovative procedure methods to tackle these emergencies. So yes, epistaxis, pulled elbow, foreign body, nose, ear, and eyes, zipper injury, torsion testis, removal of the ring which is stuck in the finger, paraphimosis, or a tooth which is avulsed, and many more. Now let us start with trouble number one, epistaxis. Now why we have selected the first this epistaxis? Because friends, 30% of children less than 5 years of age and 56% of children 6 to 10 years had at least one nosebleed. So it is very common. Everybody of us has come across these patients of epistaxis. So it is rare. This is very important. It is very rare in children less than 2 years. So when you have a patient with complaints of epistaxis less than 2 years, we should prompt a consideration of the trauma or a serious disease like thrombocytopenia. Now, epistaxis less than 10 years child, they usually originate from the anterior part of nose and they are mild. So they are not going to have much of the trouble. So we can definitely manage it. But we know that epistaxis is usually been always, their parents are been afraid and worried, anxious, and they are panicky. So we have to treat it as an emergency. And epistaxis in children is usually from Little's area, as we know that, which is a septal wall, which is there on the septal wall anteriorly. So we know that this is particularly area where we have a venous lesion, venous bleeding. It is of brief duration and it is usually recurrent. Now, technically, if we see, there can be a classification like anterior epistaxis or posterior. Now, anterior usually we have found in this younger children, but posterior we find in elderly. Difficult to treat is posterior, more of arterial, more profuse, and difficult to manage. Where anterior we can manage easily. Second can be a local or systemic. Now, local, that means local causes for the this bleeding, and a systemic, that means there are systemic causes, maybe a bleeding tendency or homocytopenia and many more conditions. So, epistaxis, there are two important factors for childhood epistaxis. One is either a minor trauma. Now, this trauma can be by simply picking a nose or sneezing or blowing or maybe just rubbing a nose. So that trauma can cause bleeding and epistaxis. Or you have a friable nasal mucosa. Suppose you have a polluted atmosphere, you have dry air, or you have upper respiratory infection, or we have used the intranasal steroids or foreign body. These are the conditions where there is a friable nasal mucosa. These are the two important factors they are causing the childhood epistaxis. Now, what is the management of epistaxis? There are so many things. These are not one by one. They can be used at any time, depending upon the situation and the condition of the patient. But we know that as it is less than 10 years, what we get more of anterior, and it is going to subside with direct pressure. So direct pressure is very important. And there are other options also. Now let us understand what is a direct pressure and how to manage these patients. So whenever we have a patient with epistaxis, usually they are panicky because many times it is recurrent and they are constantly asking us, why is this my child is getting this epistaxis again and again. And when we explain them, it is because of nose picking or because of some sneezing or blowing nose, they will say, sir, it happens in the middle of the night. So how can you explain that? Friends, we know that even a dry nose nasal mucosa can cause itching. And in the sleep, during sleep also, child will rub the nose against the pillow and they'll be bleeding. And this most importantly, these 2 or 3 drops of blood will spread on the pillow and that will look huge or very big bleeding. So they will be more concerned or anxious. So what is needed is a simple direct pressure. So this is a simple measure to stop the bleeding. What we will say, ask the child to be sit in the parent's lap like this, or child can keep the head tilted front and should be in a bit tilted one. So because we don't want a blood to go inside, so they should not swallow the blood, otherwise they'll be vomiting. Now we need to apply constant continuous pressure on the anterior portion of the nose. That is a cartilaginous. So we have a nose which is a bony part and then the cartilage. So we need to press the nose, that particularly cartilaginous part, with thumb and forefinger for 10 minutes. So we have to go beyond our bleeding time. So if you keep it pressed for 10 minutes, it will stop. And meanwhile, child has to breathe with open mouth while just keeping the head tilted forward in front and allow any blood which is trickling, either it has to go on downwards or you can collect in the kidney tray. But it should not go in the abdomen or it should not swallow, because foreign body, the blood is ultimately a foreign body. So it will not stay in the body. It will come out and there will be vomiting of blood that will cause more pressure like situation, more panic situation. So that is about the direct pressure. Suppose we have given the pressure, but still the bleeding doesn't stop. Is it possible? Yes. If there is inadequate treatment, inadequate pressure, that means most of the time what happens when we ask the parents to do the pressing or just you have to, do this simple measure of direct pressure, child will be, the parents will just press it and then within few seconds or few minutes we'll check it whether it has stopped or not, and again they'll just cause the pressure pressing. So this doesn't last continuous pressure for 10 minutes, and that's why there's a failure to stop the bleeding. Now if it is happening, then we just determine the site of bleeding. If it is coming from internally, right, the deeper part, that means the posterior bleeding, then you need to sort out some other options. But if it is from anterior only, if it is uncontrolled, we can go for cauterization or anterior nasal plaque. Now, before doing this, I think there is one more innovative method of direct pressure. Because we know that child himself or a parents cannot keep pressing for 10 minutes, we have one other thing. Can we apply nose clips, which may be a simple thing, but it is effective way to control the epistaxis, leading to time saving as well as reducing more invasive treatments. So you can use nose clips. Now, can we use the clips which are using we used for the hanging our clothes on the rope? on the string? Yes, but I think because it has been very tight, so it will cause damage to this our nose or children. So there is one innovation. Can we use this particular wooden spatulas? Yes. How? Let me show you. Just take two wooden spatula. Then you just press it or stick it with that micropore. So now the part where it is opening, it can be used to press the nose, particularly cartilaginous part. So more you go take your this micropore nearer to this portion, it will be more tighter, more tight. And if you go away from here, then I think it can be used. So we can have control over the pressure what we need to generate to keep it pressed for the depending upon the age of the child and the size of the child, or you need the pressure. So this is something very important innovation. I think we can use it in our day-to-day practice very frequently because we have this spatula lying in our consulting. Now, second option is topical vasoconstriction. So what we can use? We can use mixture of anesthetics and a vasoconstrictor because so we can have a solution of epinephrine with lidocaine. And this you can use the swab or something like gauze piece and you can insert it, soaked into it and keep it there, pressed it. So that will cause both vasoconstriction as well as some pressure effect. So that will help. Third option is cauterization. Either we can go for chemical cautery that is in form of silver nitrate 75%, or you can have an electrical cautery. So if you have electrical cautery, I think that's fair enough. But silver nitrate, I don't think we can have that. Or if it is available, if it is not available, we can use it. So important thing is in cauterization is suppose you have this patient with epistaxis. So you need not to touch at the site from where bleeding occurs. You have to go proximal to it, and we have to just do the cauterization of the vessels, which is giving the bleeding site, which is reaching to the bleeding site. So that you can do the cauterization either with silver nitrate. You can use the bud soaked in silver nitrate solution. You apply it, taking care that it should not touch any other mucosa, and just make it sort of cauterization or burns, and then it will heal. So that was about cauterization. And last thing is anterior nasal packing. I think we as a pediatrician should be knowing how to do this anterior nasal packing because an ENT surgeon, if it is not available, there is profuse bleeding, we cannot stop it. I think we should learn this. So what do you need? You can have specifically designed anterior nasal packing also, which is available in the market, like hydrocil, merocil name, and rapid dyno nasal tampons. But I think these are very difficult because particularly when I am talking about this merocil, they are just like a stick of ice cream or like wooden spatula. You have to just insert it, and as it goes inside with the hygroscopic action, it swells and ultimately it gives a pressure. And we can keep it for say 12 hours or so, and then we can remove it. So if it is there, it is good. This is available like this Merocell. It's a brand name, but we can use it. Now, if you don't have it, this is the best thing. We can have a roller gauze. And this roller gauze, we can make it soaked in a petroleum jelly. And then with the help of this bayonet forceps, this is typical forceps. We can have this specific forceps, or you can use any other forceps. But the main trick is when you start inserting this roller gauze, first 3 to 4 inches you have to leave it. And after that, you start putting inside, and we should make a serial layer. So as deep as possible, you go and you make layers like this, and last portion should come out, and there should be two ends of this dangling outside. Then you can just fix it and press it. Usually, as a pediatrician, we should do only unilateral packing. We should not go for bilateral packing because then it ultimately a specialized job. So better to send it to ENT surgeon for the same. So once you do that, then after some few hours, maybe 12 hours, 24 hours, you can soak it this. And then gradually you start removing the upper part, last part where you have inserted. That's roller gauze. You have to remove it, and then gradually there can be chances of rebleeding also, but you can keep on keeping it wet, and gradually you can remove it. So this is what we have to do it, antinasal packing, and that is very important to understand. Now, what are the do's and don'ts in epistaxis? I think do's we know that. Sorry, it's other way around. We should not. Don'ts are lie flat or recline. So don't ask them to lie flat or recline. Not to pick the nose or vigorously blow the nose. Avoid to eat the warm and spicy food, and rather you take don't take shower with the hot water, because sometimes the hot water can cause the vasodilatation and bleeding will start. Avoid the aspirin or contain drugs which can cause the bleeding, and antihistaminic or the nasal decongestion spray should be avoided. Now, what are the do's? We can use the humidifier. You can apply the Vaseline or gel inside the nose just to keep it moist, or you can use saline solution or gel that is available, aloe gel sort of things. And most importantly, ask the kids to trim the nails. I'll ask the parents to trim the nails of the patient, because that will cause a picking and there'll be a injury and there'll be a this one bleeding. So after this, the trouble number two. 2 years old boy. He's been brought with an accidental insertion of eraser in nose. We know that our children, they are very much, inquisitive nature, and particularly when they turn around 9 months and so, they have pincer grasp. So they pick up anything and everything, and they can put it in the nose or ears, and that can cause this kind of troubles. So how to manage this child who comes with the foreign body? Sorry, nose. Sorry for the misprinting. Is it needed to be referred to ENT surgeon, or can we remove it? Now, friends, we know that this is a part of the nose. We have different turbinates, and usually we see the foreign body which has been there in the anterior part of the nose. So either it is there in the anterior to middle turbinate, or it is just below the inferior turbinate. Now, when you see the patients, you can have inorganic, organic, metallic, many different types of foreign body nose. Even you can see the living larvae or the worms, and location, as I said, anterior to middle turbinate or below the inferior turbinate. Now, it is usually unilateral, and whenever it is unilateral, you have right more than left side, because right-handedness is more common. So children will pick up the things and put it in the nose. There is more on the right side. Now, for removal of this nasal foreign body, there are almost 20 different techniques that have been mentioned in different literatures. So if you broadly divide it, it is direct instrumentation, or a balloon catheter, or a suction catheter, or a positive pressure techniques. So when you talk about, say, direct instrumentation, there are different instruments we'll be talking. Balloon catheter, you can use a Fogarty catheter. You can just introduce it just on the upper part of the nose. There you have a space always. So whenever you do some instrumentation, you go on a ceiling of the nose, and you try to enter and go beyond the foreign body. So in case of balloon catheter, you pass it and inflate the balloon and then remove the balloon catheter. Second thing is, you can use a suction catheter. So you can use suction catheter, just you introduce the catheter, then you start the suction, then you just fix it. So metallic foreign body or the firm surface foreign body, they can get that suction tip stuck into it, and you can remove it. And last is the positive pressure. So I'll be showing different methods of removing foreign body, which I have tried with different patients. So what do you need to remove the foreign body? One is a nasal speculum, because that will give a proper view. Light source. Light source is very important, because usually it should be a head light source. Otherwise, when you try to remove the foreign body, you holding the, the, the torch with the one hand, or somebody is holding the torch, I think it will be difficult to manage. But if you have a head source, light source, you can adjust it, and both your hands are free, so you can do the work better. And any of the nasal foreign body removing instruments to be there. Now there are different instruments, like this is called typical nasal foreign body hook. Look at this. They are blunt from the end. So you can go beyond the foreign body and remove it. There are many people who have been very comfortable with this particular technique. Then you can have alligator forceps. This is typical. So this forceps you introduce, and when you go close to foreign body, you open it up. This particular tooth will open, and then you can grasp it. So you have, suppose, a paper, a piece, or a gauze piece, or a cotton, or this friable sort of thing that you can catch the hold of them. You can bring it out. So that is about it. Or you can use the bayonet forceps, which I showed in a anti-nasal packing in the epistaxis. So now let us see the video of the foreign body which has been taken, like brought out or removed with alligator forceps. So simply you could remove, and there the patient was very much cooperative. Otherwise, it is very difficult to when you introduce the instrument inside. And this particular, it was a cotton sort of thing, which you could easily remove it. Now, the next is a foreign body by nasal hook. I think one of my friend, Dr. Alpesh, he sent me video because he is. There are many people who are comfortable with nasal hook. So just see this video. Simply, you have to go beyond the foreign body, and because of that hook sort of thing, you can remove it or scoop it out. It's so simple like that. Now, I was interested in positive pressure technique because this technique is important because here we don't have to do any instrumentation. So, patient is not getting panicky. So, positive pressure ventilation technique says that after vasoconstriction, you either give mouth to mouth breathing to the by parents, and you try to blow from the mouth of the patient, and the foreign body should come out from the nose. Or you can use similar thing, positive pressure with ambus bag and mask. Now, typically positive pressure breath, which will expel the object after closing one nostril. That is very important. So let us try to see how and when it should be used, this technique. So foreign body knows, I think positive pressure technique indication is the foreign body is large enough to occlude the nose. So that's why it will give the push when you give the positive pressure. Second thing, it should be acute because if it is 3, 4, 5 days old, I think that is been stuck so much and there may be secretion, so it will be difficult to get it. So I think it is better to pull it out rather than push it from within. So advantage is it is less painful and frightening because it doesn't require the restraint and there is no instrumentation. So that's why I was interested in positive pressure technique because in traditional teaching in our college days or the residency days, that whenever you see a foreign body nose, don't touch it. Better to send it to re-entry surgeon because in order to try to remove it, I think you might push the foreign body inside and it can go inside and it can choke the things. So typically it is mentioned in the literature that there is a parent's kiss. So what we say, mother, to blow from the mouth of the child, keeping the nostril where the foreign body is not there, press it and then blow it. So then the foreign body should come out. So this is the thing. When I studied this thing, or I came to know that this particular technique, I was very much interested and so fascinated study, fascinating this technique. So I was waiting for the patient to come, and the first patient came. I was so excited. So I asked the mom to blow from the mouth of the child, and I had some difficulty. We look at that and what mistake I did. Just look at it. So what I did the mistake. I asked the mom to blow from the mouth, but I forgot to close the nostril. Still, I was successful to bring out because that foreign body from deep and it came out and I could just press it from the nose and it came out. So that was fortunate thing and that was really moral booster because I was just starting to think this kind of technique. But what happened that at that time the parents said, I kissed my child, I pushed the foreign body, then why should I pay you? So, anyways, that was just a joke. But I think I thought it is better to use something else because many times these kids they're having a running nose and there can be secretions. So it is very difficult or clumsy thing to go for the parents' kiss. Or sometimes if parent cannot do, we have to do it. So it is not advisable. So why not to use the bag and mask instead of that force or blow which has been given by the parents? So that's what I tried to do in our next patient. So this patient had a history of crayon which has gone inside and I took this video and look at the slow motion. Excellently, the foreign body is coming out. Look at it. But most important thing is when you are using bag and mask, just try to keep the tape over the pop-up valve because we not need a good pressure. Otherwise, what will happen as soon as give the pressure or you press the bag, the pop-up valve will open and pressure will be reduced. So that will not give enough pressure to the foreign body to come out. So look at it. So beautifully it came out with 2 or 3 puffs. It came out. This was wonderful. So similarly, I have one more patient where the magnet was inside. I think there also I use the same technique and look at the result. So that was a magnet which came out with the bag and mass. So now I tried this, and in one patient, I couldn't make this foreign body come out with the bag and mass. So that was chano, sort of chana. Chana was their soft thing. So I couldn't grab it with the alligator forceps also, because otherwise it will break it out and it will make more pieces. So can we use this UPIN which we have in our consulting? We can just make a different shape of UTIP and we go beyond it from the superior surface, and then you can scoop it out or bring it down. So I tried this in one patient, and look at that. The foreign body was very much deep inside. But because there was space between that foreign body and there was space to the, I was not able to bring that foreign body out with enough of the positive pressure. So look at that video. So this is the confession I took it from the patient, that he has instilled that chana inside, and we could remove with that. So if you saw that, so what we did it here. So here simply I made a loop of it, and so this is what it is in a different direction. So we just twist it, go beyond it, and turn it right. Then you remove it, so that this blunt end will not cause a damage to the internals inside. By chance it goes here and there, it should not make much of the damage. So that was very much useful, this trick of using UPIN. Now there is one ready-made thing, a gun sort of Noxeno. It has been prepared by some startup person, and it has been almost released by Dr. Harshvardhan, our past health minister. This is nasal foreign body extractor. So what is there? Here you can see gun sort of thing, and this particular thing segment, it is like this straight, and there you can use the sleeve, just like what you do in otoscope. You have a different sort of thing which you can change every time. So here you can use this sleeve, and you can remove it for either each patient differently. So we can clean it. So this is reusable thing. So when you press this, this will this particular portion will take a band. So once you go beyond it, and particularly this is having a light source also. So that is very good. So we can have light source. You can go beyond the foreign body, take it, and you can remove it. So this is also available. Maybe this was launched in 2017 or 18, and it was 5,000 rupees. And they ultimately targeted to be distributing to all the the government sector hospital in periphery for this foreign body removal. Now trouble number 3, eye injuries in children. Now, these are very common. We know that foreign body in the eye can be found because now two-wheelers, the children are standing in front, and there can be a dirt, or whenever foreign body, it can go inside. So the patient can present with a foreign body in the eye. Or now in COVID times, we know that we are using this sanitizer a lot. So there is an exposure of chemical injury to the eyes. So accidental exposure of hand sanitizer or a household cleaners or drain or over cleaner or fertilizers, these all are possible. So this is called chemical exposure, chemical injury. So this we need to understand how to manage this sort of injury, because these patients, they come to you directly and you have to be answerable. And lastly, we can have accidental application of Fevikwik. I have seen one or two patients with a Feviquick application. By mistake, they are using it. And that's really a very tricky situation how to handle it. So when we have a chemical injury or exposure, we know that I pH is around 7 to 7.4. That is a neutral pH. So we can have either alkaline solution or acidic solution. So both can damage the layers of the cornea. So first, we should be knowing that water is acidic or alkaline. And usually we think that acids are going to be more dangerous, but here it is vice versa is true. The weak acidic solutions, they are better than weak alkaline. Why? Because alkaline solution, they penetrate anterior chamber within 45 seconds and they can cause a damage to the anterior chamber and iritis. While in acidic solution, they make a layer which can prevent the further entry into the anterior chamber. So if you have, suppose you have the sanitizer, I think they are acidic in nature. So here they can, after some time also, if you do the treatment, I think that will be better because that will not cause more of a chance of iritis. So what is the immediate treatment? First and foremost, ask them not to rub the eyes because immediately as soon as it has been exposed, the people will be having itching or there can be redness or the congestion and there will be so much of pain. So children or person would try to rub the eyes and that will cause more damage. And most of the times when you have foreign body, usually it goes to the superior and inferior fornices. So then there, they will not cause any problem. But when they try to rub it, they can come on in the front and there can be damage to cornea. So ask them not to rub. Just splash the water in the in the eye. Try to clean it and put a gauze piece over it, and ask them to come to you. Now, what we are going to do? There are two things. One is eye irrigation. That is, it is used to flush the particles and harmful chemicals from the conjunctiva and cornea. And we need to learn how to do eyelid eversion because most of the time these foreign bodies, they are into the palpable conjunctiva or into the fornices, superior or inferior. So we need to learn how to do eyelid eversion. So typically we can use that earbud and then you can put it on the superior surface of the eyelid and then evert it. It will stay there and you have to keep it with that bud only open. And then you try to see whether there's a foreign body there or not. So let us see the technique how to do it. This is a small video, animated video. Look at this. You put it this here and then evert it. And then when you see foreign body, you just roll it over and you can remove the foreign body. So this is very simple procedure, but we have to expertise it and that can be helpful. Now, once you have history of chemical exposure, you need to go for eye irrigation. Yes, parents will just do the splashing, but that will not clean the things very clearly. So for eye irrigation, what is the solution to be used? You can use RL or normal saline. How long to be done? It should be done for at least 20 to 30 minutes because we need to make the eye pH normal, neutral. Suppose there is acidic or alkaline, we need to flush it till it becomes neutral. So what will we do? First, we will see whether it is a acidic or alkaline or a neutral pH. So ideally what they do in lower fornix, they try to put a litmus paper and then you see whether it is acidic or alkaline. But you may not have this litmus paper. So what we can have, we have a urine dipsticks. You just see, I think fifth or sixth part of it, it is having a pH mark. You cut it across and use the stick to use it in the eye and you can see whether it is acidic or alkaline. Now, after that, before doing irrigation, you need to do the anesthetic drops application, local anesthetic drops. So how you will instill the local anesthetic drops? Just you have to do this, open the lower palpebral conjunctiva and open it and you just instill there. Never instill directly on the eyeball, otherwise it will cause damage or pain. So put it drops here and ask the patient to close the eyes for some time. That will give anesthetic effect. Then next step is ask the person to tilt the head towards the side of the eye which has been affected. And you can keep the kidney tray there. So when you do the irrigation, all the water or the saline will go in and collected in that. Now, so what is the typically we do? We take a normal saline or RL pint, you apply, you attach that IV set, and IV set, you just instill or do the irrigation in the eye. So how will you do that? You have a control, because there you can have a control over it. So the flow rate can be controlled with the flow meter. And then typically when you try to do this procedure from inner canthus to outer canthus, so you have tilted your face towards the affected side, you will give the irrigation around 2 or 3 centimeters away from the eyeball, so that it doesn't touch the eyeball, and continuously give the irrigation, and the fluid will come out. So that particular thing will not go. Suppose if you are doing in other way, then all this chemical fluid that will go into the normal eye also. So you have to do like this. After doing it, you need to check again for pH for 5 minutes after that, because otherwise that whatever fluid you are using, that will be wrong pH. So what is the target is, we need to have a neutral pH so that everything has been washed off. So that will be saving your eyes. Now, when you have suppose acidic solution, we know that it will just make a layer, which will not go into the anterior chamber, but it is alkaline. I think we need to instill the pupil dilated drops. So dilator drops to be instilled, so that will cause relaxation and that will prevent the iritis. So after doing this, you may have to just put the cause piece, and or you can use a betadine with normal saline solution, and you put few drops and you clean it, so that will work as an antiseptic. Now suppose there is a fevikwik which has gone into eye. First you do local anesthetic drop, you have to instill, then thorough irrigation or proper profuse saline wash to be done. Then again you instill the anesthetic jaw drops, and you can use a earbud or a cotton tipped applicator soaked in betadine with saline solution, and you can do the superficial debridement of the cornea, because this is been attached to superior layer. So you just do the superficial debridement even on the upper conjunctiva palpable as well as lower. So both the fornixes you clear it, and you apply iPad and rest for 12 hours. And that particular first layer which has been removed, that will regenerate. So usually you have to check for the acuity of vision later on. But usually with Fevikwik removal, the results are very good. Now trouble number 4, a foreign body ear. Whereas we say talked about the foreign body nose, anything and everything you can think can be found in ear, like a toy, a bead, earrings, a folded papers, a biological material, anything. So, and as the pincer grasp developed in 9 months, this is very common. Now, what all things we need for the foreign body ear removal? I think we need to have a otoscope with head mirror, strong light source, as I said, for any of this ENT procedure, because you can have both the hands free, you can manage proper. And there should be some instrument which can be used to remove the foreign body from the ear. Now, what are the indications for foreign body removal? See, you have to remove promptly whenever there is a well visualized foreign body which is seen in external auditory canal. And look at it. If there is a perforation of eardrum, or if you think that foreign body is then there been stick to the tympanic membrane, or there is incomplete visualization of foreign body, I think we should not try to remove it. Most important, then there is history of button batteries in the foreign ear. I think urgent ENT reference, because here there will be time sensitive liquefaction necrosis, so there can be a tympanic membrane perforation. So it's a very critical situation. We have to send them to ENT surgeon as early as possible. Now, what are the methods to remove? I think irrigation, that is what I will be showing it. Suction with 100 to 150 nanometer pressure. Here, you just suck it out, the foreign body, or you can use an instrument like curette or paper clip, again the bent one. You go inside, beyond it, and remove it. You can use acetone for super glue or chewing gum or styrofoam. Lastly, live insect. Before doing any procedure syringing, you can still few drops of oil or lignocaine that will make movement less, so patient will not have pain while the foreign body is alive, live insect is inside. So this is what I was telling, that you can use alligator fossils, particularly for graspable foreign body like paper or cotton or foam. You can use suction tip, and here non-graspable, round, smooth, and free-floating bead or pin. You can remove it. You can use a curette sort of things or a U-pin. You go beyond it and remove it. Non-graspable, round, smooth, and free-floating foreign body. And lastly, if they are non-graspable, round smooth, we can try this irrigation of the syringe. And here you are going to use this scalp vein needle which you are having. Just cut it to front portion, apply it to the 26 syringe, and then you give superior and lateral. So this is what it has been shown. Curate, you can remove the foreign body, and this is syringing or irrigation. So direct stream should be directed towards the posterior superior aspect of it, never direct towards the tympanic membrane. Use a lukewarm water, and it is contraindicated if there is a perforation. So let us see. I tried to remove the foreign body, but I didn't have the patient, so I did it in a normal patient. Only thing is to show the technique how to do it. You use the syringe 20 cc, you apply scalp fin, and you cut it the needle portion, and then you use it, and you forcefully introduce superior and laterally, and the foreign body will come out. So here the wax came out. Look at this video. So this is how you can remove. Here there was no foreign body, but I could remove the wax. So trouble number 5, a 4-year-old uncircumcised boy brought to your clinic screaming and bleeding at the site of penis with penile foreskin stuck in the zipper. Now this is a situation which is very, very bad situation, because usually the patient is so much panicky, and usually it happens because the child is having always in a hurry to go and pass the urine, and as soon as he passes urine again he has to rush to play. So that's why he just tried to unzip and zip and unzip very quickly, and usually they are not wearing undergarments or underwears, so the foreskin that gets stuck into the zipper. So this is situation, and it is very common, as I said, in uncircumcised male while zipping too quickly, and there is a severe pain, agony, and patient is very much anxious. And the key to treatment is ask them to avoid the further manipulation of the zipper, because at home if they try to manipulate, there are chances that the skin will more get stuck into the zipper. Now, when you see, these are the teeth of the zipper, and this is runner, right? And this runner, it has been having a 2 plates, and it has been attached with the central portion, which is keeping the 2 blades together. Now, there are 2 types of zipper injury or entrapment. One is, which is common, is foreskin gets stuck into the movable part of the zipper. So here, runner, or you can just go across and the skin will be found in between the teeth of the zipper, wedge between these two. So if you have this kind of both the things, this is very common. And the treatment what has been suggested is you split the median bar. Now what is median bar? Look at this. This particular portion which is keeping two blades, flat blades together. So you have to cut it. If you cut it, then it will open it up, and that will cause opening up the zipper. Now, so here you have to cut it. Look at this median bar. Second thing, so here also it has been shown very clearly. This is median bar. Suppose the patient is has overrun and the skin is here, right? Then what can you do? I think in few of this this zipper, which are, suppose if we talk about jeans pant, they are very sharp, we cannot remove. But in certain zipper, what we can do is, if the skin is there in between, then you can cut across from here, and that will open it up. Look at this video. So that where you cut it and you can get the zipper open. Now, there is one technique which has been demonstrated, that if you use this screwdriver, flat portion of it, and you insert in this place between these two face plates, and you just try to do this twisting movement, and that will cause separation of both the face plates from here, and I think you can open the things. But unfortunately, or technically, you can't use this particular screwdriver when you have a patient with the zipper and the skin in that particular runner, because when you try to do fix it and then you do twisting, there are chances that you might injure the child, and patient will also be very much panicky. So we had some other method which I tried. I think, can you see this particular instrument? I think this is the thing which we have on in our stationary part of our consultation, where for currency note bundle opener, we can say it is having a V short of thing, and it's also angulated. So we use that to remove it. So first, when I tried to remove or separate the faceplate by just cutting the median bar. So I thought it must be very simple, but I tried a lot, and I just kept the timer with me. And in the mobile, you can see the video. And then yet I tried to use the cutter very forcefully, but still at 50 seconds, till 50 seconds, I tried hard, but couldn't do it. So it was very difficult. And then I used that particular currency note opener, a bundle opener. And look at this. What technically I can see is, whenever there's the two blades, you can just insert by the side of it, this particularly bundle opener, twist it, and then it will separate it out. Look at this. Even at 52 seconds, I am not able to open it. And by doing this much of pressure, I damage this cutter also. So just imagine when the patient is there with this particular situation, if you lose this sharp instrument, it is going to have a very tough time. So now you look at this, I use this particular thing which is lying there, and look at this. So within 14 seconds, 13 or 14 seconds, I could open it. Just twisting moment, it separates the blade. So I think this can be useful. And I was waiting for my patient to come and apply this technique. In vivo and in vitro, it is a difference like. So I got the patient and I tried that successfully. So you saw that. I could open it up very quickly, and then I tried to separate it. That took some time. So this is a technique I think we can try it out, because we have everything, and we can definitely try it out. Now, trouble number 6, a 9-month-old child brought with a complaint of excessive crying since one day. When we undressed, we found this. If you can see this, the left testis is swollen, a scrotal swelling is there, and there is redness, and child is in excruciating pain. So, what it could be? I think there's a dictum that whenever you see a swelling of scrotum, unless proved otherwise, it is a torsion testis, and we have to act like that. So, what are the clinical symptoms? Sudden onset of severe scrotal pain, nausea and vomiting. These are almost majority time in younger children. You find that. and tender swelling of the testis. Many times it is very difficult to diagnose this because the patient, unless you undress, you will come to know that there is something around the hepatitis cyst. So patient will be crying a lot, there will be nausea, vomiting. You might think it's abdominal pain and you might miss this torsion testis. And there's a diagnostic trial, acute scrotal pain, which is less than 12 hours, high riding testis. Because there is a twisting and torsion, the testis will go up and it will become horizontal. So that is called high riding. And there will be absent cremasteric reflex. It is when you stroke at the thigh and there will be retraction of testis on the normal testis. Usually in infantile age group, I think we might not elicit absent cremasteric reflex. But when you don't have the cremasteric reflex, I think there are chances of torsion testis. So you can diagnose by ultrasound scrotum, but what is important is the Doppler study because there will be decreased flow that is to be documented, or you can have a nuclear scan which shows the decreased blood flow that will diagnose. But if you have all these things, and you need not to worry because you just send the patient to the pediatric surgeon. But if you don't have those facilities, and if you don't have any surgeon or any surgical help nearby, so we know that time is very crucial in torsion testis. So if there is a delay in detorsion by 4 to 6 hours, within 4 to 6 hours, you can have 100% viability of testis. If it is done after 12 hours, before 24 hours, I think 20% viability. So viability goes down very fast. And after 24 hours, if you see the patient, I think 100% of the time you have lost the testis. So what are the indication of manual detorsion? So suppose you think that there is no possibility, so there is going to be delay in seeking some neurosurgical consultation or a surgical help, and patient need to be transferred to some other facility which may take a sizable time, and if that is presented before the scrotal cavity develop, so I think that is a time you can try the manual detorsion. Now, how can you do that? See, we let us understand, almost two-thirds of time, a torsion is occurring with inward 360 tweak. That means, suppose if you have your testis, this is right testis, and it will turn inside for 360-degree. So what you need to detorsion, you do it reverse. So if it has gone inside, then you take it outside. Look at this. This is a high riding, horizontally lying testis. You just make it other way around, and then you will make a detorsion. So if you see like this, the torsion is occurring in a medially. So when you want to do the torsion, you have to just open the book. So it will be clockwise for the left testis and anti-clockwise for the right testis. Now look at this. How will you come to know that there is a successful manual detorsion? Because there will be relief of pain and there will be position testis can be brought down, which has been high up. And if you have Doppler stethoscope, you can see the return of pulsation of arterial pulsation. So this is what I try to explain with a video. Unfortunately, I don't have the patient with the torsion testis, which I had to do the detorsion because I am practicing in an area where the pediatric surgeon is just a call away or very nearby. So I don't have the possibility to get the patient. But let me try to explain how exactly on the dummy I can show you. One of my friend's son is acting into it, and look at this video, and it will be self-explanatory. So this is how you can do it in a select situation. Friends, this is a situation where you know that you are not going to get any help nearby in near time. You can definitely try it out. No harm in doing it. But many times it might require some sedation because this is going to be a painful procedure, and patient might not allow you to touch the testis. So that is what it is a caveat. So in my case, what happened? I just went for sonography and it showed that there is a possibility of abscess formation. So suggesting epididymitis, but I was not convinced. And that's why I got for again repeat sonography. And there a Doppler also was done. And what it was shown that there is absent vascularity in left testis and epididymis, and increased vascularity seen in the left spermatic cord. So the findings suggestive of torsion testis. So I was a bit late in diagnosing, and finally, what I got is this total loss of the testis, totally gangrenous testis. So, friends, this is very important message. Whenever you see a patient with a scrotal swelling and painful scrotal swelling, unless proved otherwise, you try to manage it as a torsion testis. It should be very quickly sent to the for the ultrasound with Doppler and should be sent to the surgeon. You may save the testis if it has been done within 4 to 6 hours. Now, trouble number 7: an infant brought with a penile foreskin like this. I think the diagnosis is very clear. This is paraphimosis, and we know that because of there is a tight ring when the person tries to you know take the skin away, open it up, and they are not able to bring it down, and then ultimately it causes a very tight strangulated thing and edema of the this prepuce as well as the glands. So what do we need to do? First is there are two techniques of reduction. One is with the closed fist, and second is with fingers and the thumb. So first the technique is, first you have to press it with the fingers of with the fisting like this, and try to reduce the edema. Because there is the edema of the prepuce skin, I think we try to keep it pressed for 5 to 10 minutes, and that will reduce the edema. And then you try to do reduction. So with this technique, what you do, you just try to hold the penis like this, and you use the thumb to press the glands inside and bring the skin over it. Or you can use the fingers, that is index fingers on the dorsum of the penis and rest of the fingers on the ventral surface, and use the thumb to push the glands inside and bring the skin back into the position. Now this is if it is better to use certain lubricants, or you can use a glycerin maxil dressing to reduce the edema, and that will help. So this is a video where I didn't use that uh, uh, sort of things to make it smooth or some lubricant, but I tried it just like that. Look at it. So here I could show both the techniques. Initially, I tried to do with the fingers, and so I tried to do with the fingers. Sorry. but I couldn't succeed. So I'd use the fist method and then I press that thing. So this is a painful procedure. So I could manage it, but you can use something like you can use something, some procedure to reduce the edema first, and you can try this. Now, trouble number 8. Here, a child was brought with a complaint that he is not able to move one of the upper limb. Now, can it be a pulled elbow? Now, what is pulled elbow and how it presents in our OPD? Is it that simple to diagnose, or there are chances of wrong diagnosis also, and how to manage? Let's answer all the questions. So we have 4 different cases where all complaint were not moving one of the upper limb. So look at this, the first child. Okay, this is a second child. You can see this child. There are some marks of infections, maybe of chickenpox. A very toxic looking child. So all 4 are complaining of not moving upper limb. First child, if you remember, there is having a typical of pulled elbows. This also child. Third child, where we had a newborn, I think no point for guessing, it's a upspasy. Last was a very toxic looking fever, so infective condition. So when you have a patient where the child is not moving upper limb, there can be a fever, systemic unwellness, or inflammation. Look at it. If they are there, consider infection, osteomyelitis, optic arthritis, whatever. If it is not there, look at the swelling. Other than mild edema, if you have bruising or deformities or tenderness, I think you go for X-ray. If you don't have that, by diagnosis of exclusion, we have a pulled elbow. Then try to reduce it. If you are successful, send them home. You try twice, not then you go for, send for the expert. Now, what is this pulled elbow? Here, the outstretched hand, externally rotated, when there is a traction which is given vertical, there is a twisting movement. And here, the radial head, it comes out of the annular ligament and it causes pulled elbow. So this is a typically partially slipped radial head and also called nursemaid's elbow or pulled elbow. So what do you need? You need to do a reverse movement where you can replace that particular radial head, which has been subluxated from the annular ligament back into the position. So usually what we found, then when we are holding or lifting the child with one hand, or the parents are going into the gardens like this, and they make the child swing, and this is a position when there is a pulled elbow. Or you may have, usually we see this patient 1 to 3 years of age, or maybe 1 to 5 years or 6 years, typically 2 to 4 years maximum. But we may see a 6-month-old child with pulled elbow because child will just roll over, and by that position, they may have the pulled elbow. And how will you diagnose? They have typical position where child will keep, whereas it has been shown in this, sorry, it's not there. So position like this, you have a flexion at elbow and there will be a pronation. So it will be painful when you do the elbow movement or you do supination. It will be painful movement, and that is the diagnostic. Usually, we don't need an X-ray for diagnosis, but many times X-ray can be therapeutic because when the patient is going for the X-ray and they do some manipulation by mistake, accidentally or incidentally, it gets corrected. So that is therapeutic X-ray, but it is not required unless you have the possibility of the sort of say you think it is a fracture, then you go for X-ray. Now, pulled elbow, what are the management techniques? two techniques are there. One is combination of supination flexion and second is hyperpronation. So what is this technique? Here 90-degree flexion you have to keep at this elbow. Then you give a bit stretching. You shake hand with, suppose left hand, you could give your left hand with your, so you just shake the hand and then first you supinate the wrist and then you immediately flex. When you flex it, you get a pop-up sound or a click. And that once you listen it, that means the radial head has again gone to annular ligament. And second is hyperpronation, where you fix it and at 90-degree like this, hold both the condyles and elbow, give a bit stretching and hyperpronate it. That will again cause a uh, reduction of the pull elbow. Now look at this particular video. So here, look at the typical movement, because you have to fix it, then stretch it, supine it, and then flex it. Look at once again in a different video. So child is getting pain when you typically reduce it at that click or the pop-up sound. At that time, child is getting pain and then absolutely pain-free. Many times what happens that immediately after doing it, child may not move that particular limb. So just give some time, 10, 15 minutes, or you give some painkiller medicine, because many times few hours have passed, then that can be a painful condition. So even after reduction, child might not move the limb because of the fear. So just give some time, and after giving some painkiller, child will be absolutely normal. But you have to be very sure you have got that click. So you can try twice. You can do the maneuver once and twice. And after that, you should send it to the experts or rule out the diagnosis. Usually this can occur again and again. I have seen one patient 4 times this pulled elbow on the same side. So then we have to teach this technique to the mother and we say simple. So this is one more technique, this is hyperpronation. Look at the position of the patient and how fix it at elbow, make a 90-degree, slightly twist, and then you hyperpronate it. So this is simple, but I think what has been shown in literature that this is a better technique or easy technique, but I am more comfortable with the supination and flexion technique. So if you fail after 2 attempts, I think you make a sling, and there are specifically makeshift sling ideas. You can use this scarf and make it like this. First you insert like this, you put a hand, and then you like it here. Or you can simply put it inside your unbutton middle button and then put the hand like that. Or you can use the scarf like that. Now, this is a trouble number 9, where 12-year-old girl came with a ring which is stuck in the finger. So naturally, the patient relative must have tried a lot, maybe using lubricant and all that. But if they are not tried, you can use lubricant and try to this remove with some twisting movement and take up the finger. You try to elevate the digit so that the edema will come down. Because what happens when you try to, when the ring is stuck, that there is a swelling in the proximal, the distal portion of it. So either you immerse in the cold water to decrease the edema and then you can try it out. But if it has not been done, then there is a string method where you can use two-way. You can use 3-0 silk, where the distal part of border of this ring, you start applying the string. First, you have to pass it beyond the ring and keep it the other end of the thread out, and then you keep on winding so that edema will go down. And once it has been pressed, you can remove the ring by just making a twisting movement, or you can remove the unwind the string from the other end. So I'll be showing it in the video. So this is what we are doing. So this A end and this B end. So once you have used it, this wrap it like that, and while removing it other way, so that will gradually slip the ring on the finger. And this particular, when you wind up, it should go beyond the distal interphalangeal joint. So you keep on winding this 30 silk, and then you try to remove, unwrap. Look at the video. This video courtesy Dr. Suresh Gupta sir from Delhi. So now last trouble is Eval's tooth. Now we may come across the child who has been injured and there's a fall in the tooth and they come with a tooth. So what we do? Reimplantation and how and when. So there are some important facts for that. Always handle the tooth by its crown, never touch the root, because that is very sensitive portion. When you do reimplantation, like it is indicated only during for the permanent tooth, naturally for not for the primary tooth, deciduous tooth that will come again. And time factor is very important as far as this Evers tooth reimplantation is concerned. 20 to 60 minutes is the best chance for survival of permanent tooth. So what do we do? You just clean the Evers tooth by just curling movement in the saline, and then you just clean the socket from where you have to insert it or reimplant it, and then you reimplant the tooth by proper fitting it and stabilize the tooth, and put a gauze piece and ask the child to chew it and keep it like that, and then you send to the dentist. Now ideal is you have to do immediate reimplant, but otherwise you can manage say 20 minutes to 6 hours if you keep it into the milk or a special solution called HBSS. Now if the tooth was kept in moist, that it means either in water, saliva, then I think 20 to 60 minutes is okay. But if it goes beyond, I think we have to transport in a proper media. So today, sir, friends, we just tried to touch upon many of these emergency procedures. Few are left out, but I think this because of time constraint, I'm just stopping here. So I hope you all enjoyed the talk. Thank you so much for the wonderful opportunity, and let's have the question answer. Thank you.